And welcome to the Davies Use Case webinar being presented by Parkland Health and Hospital System on Universal Suicide Screening Program. This is a Davies Award-winning use case for the value of health IT. I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Is health IT to improve the quality of healthcare delivery. HIMSS promotes integration of clinical decision support and best practice guided access to clinical data to analyze progress, and IT enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who utilize health information technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. So it's my pleasure to welcome our speakers for today's call, Dr. Kimberly Roten, Director of Quality for Safety and Education and Implementation, and also Dr. Celeste Johnson, who's the Vice President of Nursing and Behavioral Health. So, over to you all.
We're so happy to be here today to talk here at Parkland. So our goal today is to tell you a little bit about the suicide screening program that we created at Parkland a couple of years ago and what we've learned from it since then, and show you a little bit about what we built in our electronic health record to make this work. So thank you for the kind introduction. This is Kim Roten. I'm going to start us off and talk a little bit about the program and how it was constructed, a little bit of background information about suicide screening in the United States in general, and then Dr. Johnson will speak for a little bit about safety measures that we've taken at Parkland, our education practices, and then I'll speak again at the end and talk a little bit about data and future directions, and if we have time, I'll share a couple of important case examples that we've collected over our time with the program. I'll start out by talking just a little bit about the problem of suicide in the United States. All of this data is from the Centers for Disease Control and Prevention, and that data lags about 2 years behind. So what we know from 2015 is that suicide was the 10th leading cause of death in the U.S., and that's a pretty stable statistic. It's been the 10th or 11th cause of death for quite a long time now. It's the 7th leading cause of death for men and the 14th leading cause of death for women. And in 2015, there were over 44,000 suicide-related deaths in the United States. And I have to say that's probably a pretty significant underestimate. We do think that we're getting better at identifying cases of suicide in the medical examiner's offices, but certainly we still have challenges there. So 44,000 deaths in the U.S. in 2015 relates to a rate of about 13.2 or 13.3 per 100,000. And again, that's another statistic that's been relatively stable. And then for the same time period, more than 500,000 patients were treated for self-inflicted injuries in our emergency departments in the U.S. And again, this is probably a pretty significant underestimate. We're doing our best to capture these cases, but we probably all know that coding in our emergency departments can be a challenge. And so accurately capturing cause of injury is something that we're really working on across the country. And so we suspect that the number there is actually a significant underestimate of what we're truly seeing in our emergency departments, not to mention the cases of self-inflicted violence that are never seen in an emergency department. So a little bit more about what we know about suicide. In the table on the left, you can see causes of death in the United States broken down by age group. So on the left side are our younger age groups, beginning with kids at the age of 10 and then moving up through 55 to 64, and then the final column on the right is all ages, and that's where you see suicide is the 10th leading cause of death. And of course, for our kids or our younger adults, you can see that suicide is either the second or third leading cause of death, and that's been pretty consistent for many years now. So obviously, this is a real challenge for us in the United States, and there have been a number of calls to action. Probably the most recent national call to action was the 2012 report from the U.S. Surgeon General, and that was a National Strategy for Suicide Prevention, and it's a really nicely done document that describes our current efforts to address the problem of suicide, what we know about the problem, and what kind of progress we still have to make. And I pulled out some of the key points from that. So on average, between 2001 and 2009, more than 33,000 Americans died as a result of suicide, which at that point was one person every 15 minutes. And obviously, based on the 44,000 statistic I showed in the previous slide, we know that that number is creeping up, unfortunately. We estimate that about 8 million adults report serious suicidal ideation in the previous year. About 2.5 million report making a plan in the past year, and more than 1 million report making a suicide attempt in the past year. And parents or educators, of course, many of our children report similar troublesome thoughts about suicide. So for kids in high school between grades 9 and 12, nearly 8% report having attempted suicide one or more times in the previous 12 months. So in our nation at this point. That we're asked fairly frequently is, what led us to start universal suicide screening in the hospital? And it's that word universal specifically that's really the key. So what we know about predicting suicide risk is fundamentally that we're not very good at it. But an additional piece of information that we have is that most of the patients who end up dying by suicide are much more likely to be seen by non-behavioral health care providers. So they're far more likely to be seen in primary care settings or in the emergency department, where arguably providers and nurses are receive less training to identify people who are at risk and treat them appropriately. So the data that you see in the first portion of the slide reflects the fact that about nearly half of patients who die by suicide see a PCP within the year before death, and more than 3/4 see a PCP within the year before death. And in the emergency department, approximately 40% are seen by an ER physician in the year before they die. We also have a population of patients who exhibit what we call occult suicidality in our emergency department. So these are patients who present to the emergency department for non-psychiatric treatment. They come in for their ankle sprains, shortness of breath, belly pain, whatever it might be. They don't have a clear psychiatric chief complaint. They typically don't necessarily report their psychiatric history, but if they're asked directly, they acknowledge suicide risk factors. So that's one of the key reasons that we tried to move forward with the universal suicide screening program. The is that we have data now that tells us very clearly that despite a lot of national and international efforts, we're not doing a very good job of addressing the suicide problem. So the CDC data tells us that the suicide rates in the United States actually increased 24% over a 15-year time period ending in 2014. And then we also, unfortunately, know that those rates seem to start increasing more rapidly after 2006. So despite a lot of national attention, our problem seems to be growing. What we've also found is that for our youngest patients, risk seems to be climbing. So this is a graph from the CDC that shows rates of death for suicide. The solid line is motor vehicle injuries. The larger dashes are suicide, and the smaller dashes are homicide. And what you may not recognize right away is that this is for kids between the ages of 10 to 14. And what this shows is that for the first time in 2014, deaths for kids between the ages of 10 to 14 due to suicide were higher than those for motor vehicle collisions and homicide. So the rates for both of those other mechanisms are declining, and unfortunately the rates of suicide are increasing. Listening to this presentation are aware that there's a national patient safety goal targeting identifying suicide risk in healthcare settings. National Patient Safety Goal 15 from the Joint Commission requires that hospitals identify safety risks in their patient population, and specifically that we recognize patients who might be at risk for suicide. What some people may not be aware of is what's highlighted in red on this slide, which is that the requirement actually only applies to psychiatric hospitals and patients being treated for emotional or behavioral disorders in general hospitals. So if you think back to the previous slide that I presented, you might be able to connect the concept that if we only follow the minimum requirement of the National Patient Safety Goal, by definition, we're going to miss a large proportion of our patients who are at risk for suicide. So this is one of the primary reasons that we decided to start moving forward with our suicide screening program. In February of 2016, the Joint Commission also released a Sentinel Event Alert, and the purpose of this Sentinel Event Alert was essentially to describe some of what we know about suicide risk identification and to provide some general recommendations for accredited hospitals regarding what they should do to identify risk more effectively. And what I've highlighted on this portion of the Sentinel Event Alert is the statement that indicates and has evidence to support the idea that targeted suicide screening does seem to be an effective way to identify individuals at risk and provide appropriate treatment. And that's really sort of a key statement. So it's both screening and a targeted suicide-specific screening that's required to identify patients at risk. These are reasons for implementing the Universal Suicide Screening Program here. We know that suicide rates are increasing despite our efforts to shift that trend. We also know that many people who die by suicide are only evaluated by providers who have less mental health training than behavioral health providers. And then the final point that I haven't touched on yet is the idea that part of the reason that we've had such a hard time developing better practices for suicide risk identification and then prevention is that we don't have the type of data we need to form an evidence base for that. So suicide in the United States, but it's a relatively low base rate event, which makes it really challenging to study as an outcome from a statistical perspective. Not to mention it can be challenging from an ethical perspective to randomize patients who are at suicide risk to different types of treatment and screening practices. So we've really sort of run into a wall in suicide research in terms of informing our screening and prevention efforts. So what's needed, of course, then is larger volumes of data so that we can actually use suicide as an outcome measure in those studies rather than relying on proxy variables like suicidal ideation or suicide attempt. So that's another reason to consider implementing more expanded screening services. In mind, at Parkland, in 2012, we first started having conversations about universal suicide screening, and I mark this as Ash Wednesday only because I remember it very well. It was a meeting in our boardroom at the hospital. It was the first time I'd ever been called to the boardroom. And I just remember at the time that everybody had ashes on their forehead celebrating, so it's a date that I'll never forget. But at that meeting, they asked me, what do you think we should do about identifying suicide risk? And I fairly naively said, I think we should be screening everyone. And the medical director of our very busy emergency room at the time said, absolutely not. You will close us down if you do that. Fair, in retrospect, that was a very naive suggestion on my part, as I mentioned. I didn't have any sort of plan in mind for responding to the patients identified by the practice. I just thought that it was the right thing to do. So later, in August of 2014, here at Parkland, we had renewed interest and revamped conversations about suicide screening, and this was primarily due to the fact that during a routine survey, a patient was identified by a surveyor who was admitted to a medicine service for treatment of primary medical issues but had a history of substance use and did not receive a suicide risk assessment. Essentially we hadn't met National Patient Safety Goal 15, so that was a finding from that survey which sort of prompted us to start the conversation again about how to identify risk more effectively. in August of that year, we started meeting on a weekly basis to try to think about how we might do this, how we might allocate the appropriate resources, and implement this across the hospital. Really importantly, we had excellent support from the beginning from our physician leadership, nursing leadership, and our C-suite administration. So what we wrote in our Joint Commission Action Plan in response to that finding was that we planned to implement system-wide suicide screening, and we expected 90% compliance with that screening, which in retrospect was a fairly ambitious goal of ours on a weekly basis. And really the biggest challenges from the beginning were identifying the appropriate resources and how to get those resources to the patients who truly needed them. We initially thought that we would be able to roll this out all at once, but we very quickly realized that we were biting off more than we could chew, and we decided to do it in a phased implementation. So phase 1 of the suicide screening program began in February of 2015 and included go live in our emergency department, our urgent care center, our OB emergency service, and our inpatient unit. Phase 2 into primary care clinics, and phase 3 is our outpatient specialty clinic. So the program that we chose to implement here requires screening regardless of chief complaint, and that's across all settings in our hospital system, as I just mentioned. And we restricted this to provider visits. So our patients who are coming in multiple times a week and only making contact with an MA or a nurse or something like that are not screened repeatedly, but every provider visit does require a suicide screening. Across most of our screening is completed by our nursing staff. MAs do complete the screening in some locations, but generally this is done at triage or at check-in at every provider visit. We did standardized education before we went live with the program, and I think Celeste is going to talk a little bit more about that. And then importantly, and I think really relevant for this particular talk, is that we use the idea of a clinical decision support system to leverage the IT capabilities that we had in our hospital to implement this suicide screening program most effectively and use our resources in the best way possible. And part of what that included was the Parkland algorithm for suicide screening, which I'll talk about more in just a minute. So the screening tools that we would use, we chose two. We are using the Columbia Suicide Severity Rating Scale, the screener version, which was developed obviously at Columbia, and we use that for our patients ages 18 and older. And we use the ASQ, the Ask Suicide Screening Questions tool from Lisa Horowitz at the NIMH for our kids between the ages of 12 to 17. And we picked these tools because they had the most solid evidence base in terms of reliability and validity, but also, importantly, because they are short and free. So the CSSRS is either 3 or 6 questions, and the Ask is 4 or 5 questions. Algorithm for suicide screening, or the PASS that I mentioned earlier. This is a figure representing that here. And essentially, what we had to do was create a system for our clinical knowledge to be translated into our electronic health record. So the CSSRS and the ASQ had not previously been built in Epic in that way. For the most part, people were still scanning in paper documents. So our IT team was able to create the CSSRS and the ASQ using their inherent branching logic. And then we used the Parkland algorithm for suicide screening in the background to tell frontline providers what to do with patients who are identified to be at risk. So for the PASS, what we did was assign a weighting to each of the screening items in the 2 instruments. We did that through expert consensus, and we assigned heavier weighting to items that we know are associated with more imminent risk. So for example, somebody who has active suicidal ideation with a plan or a very recent episode of self-directed violence. We completed our electronic health record. As I mentioned earlier, this is administered by nursing staff who have typically less behavioral health training than other people in our system. So we needed it to be very front-end user-friendly. So the nurse reads the questions verbatim from the computer screen, selects the patient's response, and then the pass works in the background to automatically prompt the nurse to take the appropriate clinical action. We create innovations to promote safety, which Celeste will talk a little bit more about. And then, as I mentioned earlier, we did roll out education house-wide for all providers, nursing staff, et cetera. So this PASS system unfolds into 3 different levels of risk: no risk identified, moderate risk identified, and high risk identified. And this was a really key development for our system. We were already doing a pretty decent job of keeping our known high-risk patients safe. So those were sort of our easy ones. We knew that they were at risk, they were imminently dangerous, we knew to put them on one-to-one. It was that middle group that we were less sure about. And so by stratifying our patients into 3 levels, we were able to separate out that middle group of moderate risk. We do not require one-to-ones for those patients, but they do get intervention from our psychiatric social workers and access to appropriate care. So that is just one example of how we were able to allocate our resources more appropriately for our patients. We were able to do a better job of respecting their autonomy while keeping them safe. A little bit, and Celeste is going to talk with you all about how we improved communication through various IT innovations. So, like Dr. Roten mentioned, and so that it prompts the nurse as they complete the screening on what to do next, very specifically, including whether to place them on a one-to-one, and whether they can leave or not, and then who to notify for follow-up behavioral health assessment. Best practice alerts also to screen and consult psychology or psychiatry or a psychiatric social worker, and then also the psych consult team does some handoffs to the primary team, both verbally and in writing as they evaluate patients. RN to RN handoffs occur as they are evaluating patients and determining what the next steps are. Our sitters who do sit with the high-risk patients receive an SBAR report, situation, background, assessment, recommendations, so that they know specifically what is going on with this patient, what interventions they need to take, and how to keep the individual safe. And then, as you can see on the right side of this slide, there is a green banner. That is an FYI flag for high risk. The top one actually is showing an individual who is under an involuntary status, and then the bottom green banner is somebody who is suicide risk, and this is, again, for high-risk patients only. As we mentioned, the best practice alert the nurses of those high-risk suicide screening patients. It lets them know what they need to do. We've actually reordered some of this based on feedback from the nursing staff and the other disciplines. The primary piece is to not leave the patient alone if they're high risk, to make sure they're either on one-to-one or line of sight at all times, and to implement suicide precautions, especially on the inpatient side immediately, to notify that provider for the consult so that they can initiate the consult, and to put in the other orders. And then if that high-risk person does try to leave, that they are to contact the police if they've not yet been evaluated by a behavioral health provider. The BPA, the provider BPA for high-risk suicide screening lets the provider know that that patient is identified as high risk and lets them know what kind of orders they need to put in, such as one-to-one observation, suicide precautions, and a consult, and so that it prompts them then to put their orders in at that point. Clearing high-risk patients, that is only to be done by a behavioral health provider. And so these are the steps in our EHR. They go to their navigator, they go up to consult, they go to the suicide risk status, and then what they can do is press the button to clear the patient for high risk for suicide. We also have regular reports that if somebody has left the hospital and that banner is still in place, that we can go back and evaluate to see, did that patient actually leave without being seen and was never cleared, or did we clear them and just forget to remove the banner, and then we can do some re-education with the providers. Risk assessments for those who are screened at moderate or high risk, whether it's being done by a psychiatric social worker or by a provider. Safety plan implementation is often a function of social work.
where they meet with the patient and through, this is a evidence-based intervention, to really engage the patient in creating a safety plan for after discharge. And so that is done collaboratively and through their relationship. Also to do some means counseling regarding weapons, pills, just to keep them secure and away from the patient who may be thinking about using one of those means for suicide. The after-visit summary, which you can see on the right side of the page, is automatically printed for every patient who is at risk, either at moderate or high risk. And it includes the suicide warning signs, also what they should do if they're in crisis, gives them referrals and hotline numbers to call, and then some mental health referrals that are in the area. We do follow-up phone calls for anybody who's high risk, who left without being seen, and we weren't able to detain them. We actually have a report that is pushed out every day, and our psychiatric social workers then do those follow-ups. And then we've done some motivational interviewing training with our psychiatric social workers in particular, who are the ones doing a lot of the assessments with the moderate risk patients and doing a lot of the safety planning, and also providing ongoing supervision for those social workers. A plan for a reporting process to track our progress and our processes. So real-time feedback occurred during Go Live and continues to occur every single day. Is nursing leadership receives reports, so does the team that's responsible for this initiative, so that we can see what the compliance is as well as what the risk stratification is for the patients that have entered the system. The emergency department and patient units and urgent care receive daily compliance and risk stratification reports. We also have reports that identify those high-risk patients that left AMA or before treatment completed, and also report identifying patients discharged with a high-risk banner in place so that we can go back and evaluate and see whether we need to intervene with that patient or just remove the banner because they've already been cleared by the behavioral health team. In our outpatient clinics, and there's 20 of those in the community where we also screen, they receive provider and clinic level monthly compliance and risk stratification reports.
And then this is Kim, and I'll sort of finish us up by talking a little bit about data and future directions. As of August of 2017, so about 2.5 years into this program, we'd completed more than 1.6 million suicide screenings in our system, and we're accomplishing that by doing it about 50,000 per month, 20,000 in the combination of the ED, urgent care, and inpatient units, and nearly 30,000 per month in our primary care clinic. In terms of risk stratification, this is a really important statistic. This is one of the stats that we didn't know when we started the program, so this is a real benefit to other systems who are considering doing this. Close to 7% of patients in our ED and urgent care report some level of suicide risk with screening, about 3% in our inpatient units, and somewhere around 2% in our outpatient units. So our ED, not surprisingly, is the highest risk area. One exception to this is we have a homeless outreach program that's included in those outpatient numbers, and that is by far our highest area of risk, which is not surprising probably for anybody who's familiar with the mental health research in homeless populations. There's a large concentration of serious mental illness in our homeless. And then finally and importantly, our compliance is outstanding. And I used to say that this was sort of a false statistic in some ways, and somebody finally pointed out to me that I shouldn't present it that way because we built a system that requires compliance, which is a good thing. So we make it very difficult, if not impossible, for a patient to get through our system without either completing the suicide screening or the nurse giving a reason that the patient was unable to be assessed, for example, cognitive impairment or obviously death. So in terms of what we're up to now, we data extraction. One of the real benefits of how we constructed the system is that it's very easy to pull data about the suicide screening. So we finally have the sort of volume of data that we need to look at true prediction of suicide. We also will be able to look at suicidal behavior. We plan to look at ED recidivism. We plan to see if we're doing a better job of connecting people to outpatient mental health care. And obviously, as I mentioned a second ago, we can finally use mortality as a true research outcome. we are doing our best to disseminate what we've learned. We've met multiple times now with people from the NIMH, the Joint Commission, CMS, and SAMHSA, and we routinely participate in national and international phone calls to try to share what we've learned with other institutions. We built this system in EPIC, and it's now available in the user library, but it's a system of clinical decision support that we think is easily applied in systems that are using other types of electronic technology in healthcare centers. So although we created it in one, we think it would move very easily to other types of systems. Expanding our telehealth program. We have some pictures of that on the next slide. So we're really hoping to leverage our telehealth capabilities at Parkland so that we can do a more efficient job of responding to patients who are identified to be at risk. So rather than waiting for a provider to physically come over to a location, we can quickly boot up our telehealth capabilities and address risk appropriately and efficiently without slowing down our workflow, which is really important in a place where we see, between 800 or 900 patients per day in our emergency department alone. So, two stories that I think really reiterate the point that we're trying to make about the importance of suicide screening in healthcare settings. The first patient is one that continues to give me goosebumps every time I talk about it. This is a case that happened on the second day after our suicide screening program went live. She was a 52-year-old woman who was evaluated by one of our psychiatric social workers after she was identified as potentially being at moderate risk for suicide during the screening process. She denied our other sort of risk factor type questions like domestic violence. She did not have a psychiatric chief complaint when she presented. As standard of practice, our social worker asked the patient's male companion to leave the room to start his portion of the questions. After he left the room, she revealed that her companion had essentially been holding her hostage in a truck for over a month and threatening to kill her dog if she left him. So naturally, the police were immediately notified. The companion fled. The patient was fully evaluated by our psychiatry team, and we arranged for safe discharge for her. And we include this example not necessarily because we identified significant suicide risk per se, but instead because we think it's an example of how we've opened the conversation for other types of mental health issues or safety issues. This I took care of. She was a 17-year-old woman admitted as a level 1 trauma after an MBC. There was a fatality at the scene. She was a prolonged extraction. The truck was on fire. She ended up with significant upper extremity burns, particularly to her right hand. She also, anecdotally, was found to be pregnant when she came in through the trauma hall, and that was news to both her and her parents. She did not know that. So, obviously, she did not have a psychiatric chief complaint on admission. In fact, she was the president of the National Honor Society, socially active. She was a varsity letterman on the soccer and cross-country team. Positive, she said yes to every item, and when I went to evaluate her, she acknowledged for the first time that she'd been quite depressed for months and had made a previous suicide attempt. So we were able to get her started on medication in the hospital. I saw her for 19 therapy sessions, I believe, during her 35-day admission, and she ended up doing very well and had a healthy baby girl at 42 weeks. So she is sort of the perfect example of the type of patient that we would have missed without our universal suicide screening program. So with all of our information, and we thank you again for the opportunity to share.
And Kimberly, that was a great presentation. I'm actually eager to go back and listen to it myself. I just want to close this webinar, some information on folks where to find this video and their Davies use case webinars, and also information on how to apply for Davies Davies Awards that can be found posted at the HIMSS Davies Award website at HIMSS.org/Davies. And again, thank you all so much for that great presentation.